Yep. On to question.
We do. We have a question submitted that we picked to answer. Let me find
We
it.
have to go through and pick at least the good questions. So, some of the questions just don't make it in. So Kyle picked a good one.
Yeah.
Sorry,
Yeah,
Kyle.
exactly. Oh, that's good. So, question from Drew on Instagram here. He messaged me, and he has I believe it's a high school football player, proximal tib fracture through the growth plate, had open reduction internal fixation. So via 3 screws, it sounds like. So not like a tib plateau fracture where they put a plate and all the screws and everything like that. Guy's going to be non-weight bearing for 6 weeks supposedly, and he's wondering. He asked, is there a use case for BFR and exercises and isometrics to help minimize atrophy? I would just say, ultimately, all right, guys, how would you approach this person using BFR to try to preserve whatever muscle we can on that individual?
Yeah, man. I mean,
okay, first off, anyone afraid of the growth plate?
No.
Nope. Kid, ORF, BFR, growth plate. Okay.
Nope.
So here's the wild thing about this fracture. It is like, if you have your tib plateau and your tibial tuberosity, it's like the tibia just peeled away along the growth plate, like behind and underneath that tib plateau. He sent me the X-ray. It's a crazy looking fracture. So all of it, caveat obviously, would depend on what does the surgeon allow, right?
Yeah.
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 And they're non-weight. And he's asking
for
about
6 weeks. For 6 weeks, yeah.
Okay.
Yeah, I would say I would do it. Specifically, if for nothing else, I would target the proximal muscle in the leg. That would be my go-to. I think this is the unique situation where we actually do have some bone data out there. So
Yes.
looks like you have that paper out there. And part of that was with an Achilles tendon repair. So there potentially is an effect, at least on the soleus for muscle purposes, into the later phases, but it does better than traditional rehab. And then the other thing that I always tell people when we talk about in the class, when the very last systemic change paper was the Bowman paper, where one leg did BFR, the other leg was free flow, and then they have another group that was just free flow, and all they did was simple table exercises: straight leg raise flexion, abduction, long arc quads, and hamstring curl. If you look at the strength changes that came out of the plantar flexors after 6 weeks of not doing a single plantar flexor exercise, you had decent changes. Now, obviously, these people weren't immobilized and such, and I get that and I understand that. But what I'm getting at is you can have an effect distal to the tourniquet, and you may have an effect on muscle without directly engaging that muscle. You have the Kubota's papers, you have Kakikai and Jamie Burr's paper, like all those papers where we cast immobilize and then we look at the effect that we ultimately can have in different muscles of the leg. So if the surgeon's like, no, I don't want you doing BFR like on the tourniquet or with exercise, then I would simply just, put it on, inflate and deflate, whatever. But yeah.
I'm the same. BFR, mat exercises, keep the thigh going, preservation of tibia. In a paper that will be coming out has already been presented from Lambert, because this kid's going to demineralize and atrophy over 6 weeks. And if you can slow that down for him, that's going to be great. I wouldn't worry about the growth plate. We haven't seen anything where we haven't seen that BFR increases fracture healing, but we've seen that it preserves bone mass, which I think would be good for this young man or girl. I don't know who it was.
It's a guy.
Yeah. Well, and because of the non-weight bearing status, higher frequency, if you can get it, would be the other piece, just comparatively to somebody else that was weight bearing, but yeah, otherwise nothing to add.
Okay, so let's be a little bit more specific too, because those papers, Kakehi, Kubota, et cetera, use 5 inflations of 5 minutes in duration, right? They were just inflate, deflate, didn't twice a day, and they limited atrophy, right? So if this person initially not going to be able to do any sort of resistance type exercise, right? So we can't use our standard rep set scheme. We've got to use the duration of the inflation as a dosage kind of parameter. We still have a decision to make with regard to occlusion pressure. So like for me, typically, if I'm doing those leg raises and those kind of things, like we talked about, like table stuff, whatever the person can do, I'm probably using like an 80% if I can. If I'm going to combine with neuromuscular stim, I'm probably going to use 100% just because that's what has been done. Although that Paul Head paper would indicate maybe you could use 80%. So there is some indication that maybe you can kind of drift down into 80%. But I think, initially non-weight bearing, you're looking to get at least 5 inflations based on what we know, and probably at least once a day. Got to be daily. If it's not daily, it's probably worthwhile, but I would say I think you're probably still going to see a substantial amount of atrophy. You're not going to prevent a whole lot. I want to progress, though. Me personally, I want to progress to neuromuscular stim on the quad in a flex position as soon as I'm able to, as soon as that surgeon is okay with that. Because like I told the guy, because this isn't going to come out for a while, but I said, you're at least trying to get like a 10% contraction out of that quad from that neuromuscular stim, right? So I want to get that on it because we know the quad's going to go away first and fastest. So the sooner I can start engaging that quad, the better with that neuromuscular stim. And then ultimately, probably me personally, I'm trying to move towards something like pedaling a bicycle, where that individual is moving that limb. You can pedal a bike when you're non-weight bearing. I'm sorry, like it's not there's not enough load going through that damn pedal that's going to make a difference, and we can at least put a little bit of resistance in there. So maybe like if I could get that range by like say 3 weeks, and I can get this kid to the point where he's pedaling, say like bilaterally with, I don't know if I go bilateral with cuffs, but maybe at least on the involved limb for 15 to 20 minutes, I feel pretty good about the amount of exercise that person's doing now on that limb. And so now I might start thinking about, okay, maybe the frequency of how many times I got to see this individual is going to come down. So maybe it's down to 3 times a week or 4 times a week versus 5 to 7 times a week or even twice a day. So I think you have to kind of look at it from the perspective of what can we get done? And that is going to dictate how you organize inflation, deflation, how many times you see that individual on a day and on out to a week. And you got to figure all that out. That's your job, the clinician, to kind of figure out like, all right, how are we kind of preserving this muscle and figuring out like when can we make these kind of incremental changes? But I think in my head right now, if I can get somebody to the point where they can do like say 15 to 20 minutes of pedaling a bike and kind of pushing through that range of motion, I feel like if I can get that person doing that 3 times a week, then I feel like I'm probably doing enough to keep that muscle around. Maybe. This is me taking, obviously, assimilating all the information that we have, right, with regard to, what studies have been done and shown changes, and going, all right, maybe this is enough kind of thing.
You got to be real world too. You might not be able to get the kid in every day. And like the Bowman stuff wasn't daily. Lambert's Achilles stuff wasn't daily. So if they can at least
those are also active people. They were loaded. They were normal, healthy folks. They weren't unloaded.
You can even do ankle pumps with TheraBand with a tib plateau.
Absolutely.
And then you can put your cuff weights around the knee for your leg raises. I think the challenge though, and unless this kid was with a team or with a university, you're not getting them in twice a day.
I'm ignoring that, y'all. Like, I don't care. Like, I don't speak in that context. Personally, I don't. Because let's say this is a family friend, right?
Yeah, but Kyle, this is the
No.
reality.
I understand that. I practiced for 15 years, bro. I know what the reality is
Here
of
we
what
go.
we can do.
There we go.
All I'm
We're
saying
talking-
is,
you have to consider.
I'm no. Let me finish, bro. All I'm saying is, we want to figure out what can we do, what is possible within the parameters of what we have. It's the clinician's job to figure out, well, what can I do within the constraints of the healthcare system that we have? That's an entirely different topic that you guys are discussing from what I'm discussing. I'm not discussing what I have access to in reality within the American medical system. I don't freaking care about that.
Right.
I want to know what is optimal, what can I do? Because the reality is, if I care about the patient and I have a facility that I work in that cares about the patient, that person's coming in for free 2 days a week. We did that all the time in our clinic because we gave a rat's ass, right? So your total needs is freaking stiff. They're going to come in, they're going to get the physical therapy that they pay for and whatever, and then we're probably donating care 2 days a week because the person freaking needs it. We shouldn't have to do that, but clinicians do it all the time, all around the US, right? So the discussion around what do I get to do does not interest me in the least.
Yeah.
Sorry, soapbox. I know it's where we live in. I lived in it. I practiced in it. I get it. But I'm going to present you with what can we do? Now you figure out how to take what do we have the ability to do and squeeze it into what you actually get to do.
Oh, real quick, take the bonnet off and let that be out.
You guys got me fired up. You got me. You pushed the button.
No, I mean,
you pushed the button. I'm telling you.
In this
It's just
installment of Kyle's Fantasy Land,
but Kyle,
It's y'all.
I'm not.
Don't.
Kyle,
here's the thing.
Don't play devil's advocate here. You're having one conversation. I'm having a totally freaking different conversation. I don't care about the conversation that you want to have right now. I want to know, what can we do? What is possible within the realm of the things that we know? Completely separate from what do you get to do within the American healthcare system.
So you mentioned about like donating and do pro bono 2 days a week. Here's going to be the problem with this approach is you're going to
Zach, I've done it, bro. We did it all the time.
Okay,
so it doesn't make money.
Kyle, here's the problem. You're going to burn through a year's worth of visits during this 6 weeks of non-weight bearing period. Then
I know all of this, bro. Like, I get all of that. I'm not saying you can do this within the healthcare system.
Okay. Well,
I'm not saying that. That's never come out of my mouth.
I am sure that then that advice is helpful for this kid that's being managed within the American healthcare system. At some point in time,
it's a family friend.
The thing of it is you have to, like, there's optimal, and then how do we optimize the reality? And
right.
So
if you don't know optimal, if you don't know what optimal is, you can't figure out the other.
Okay.
I think we're saying the same thing here, guys. I mean, Kyle makes a great point of we need to understand and tell people what the fantasy version of, if I could do whatever the heck I wanted without the constraints, with, if you were in the DoD, if you're in a professional or collegiate sports setting where the number of visits don't matter, then do this.
But the reality is people get to do that. What I described, people can freaking do today. Right.
Or if you're in concierge care, or if you have the ability to provide pro bono for some days, yeah, for sure. But then I think it's also good to look at the other side of the constraints of, the system, because there are a lot of people that operate in that space that also need to figure out, what sort of strategies could I use in the constrained version to maximize what I get from those limited sessions.
I agree with that. But the point I would make to you is that the only thing that changes with regard to what I just described is the number of times a week you can do it. That's literally it. because everything else is based upon what can the person do, right? I mean, that's literally the only thing. So some people can do this twice a week. You can argue like, well, does it matter? I don't know. You know, it may not freaking matter at all. And it may just be better to say, wait, you know, don't even come in until we can actually kind of start working on these things that are going to matter for your recovery that we can get paid for, you know. But if the world's your oyster and you can kind of actually take care of someone like they deserve to be taken care of, I want the people that listen to this podcast to be able to deliver on that promise. Is my point. That's why I get fired up about it. Sorry.
You don't have to. I mean, there wasn't anything wrong with it.
Just sucked all the air out of the room, mofo.
Well, now y'all know how to push my button, you know? Not that y'all didn't already.
Yeah. Well,
But then I think the end goal is the quicker they can start exercising, the better, because then you can reduce those visits and probably get
Absolutely.
a lot of bang for your.
Yeah, I mean, that should be what we're trying to do as clinicians, regardless, right? Is, you know, how can we reduce this person's dependence on us, on our facility, on the things that we provide, and how can they do it on their own?
can I ask y'all a real question though? You know, based on what we're talking about here for, you know, mat-based exercises, and we've talked a lot about the straight leg raises with BFR. How many times do y'all see people complete 80% occluded straight leg raises with BFR in the first few exposures?
How many times have I ever done that on a patient? I've never given straight leg raises BFR to anyone. But
Zach?
no, to your point, it's very hard.
Do you issue out those straight leg raises with BFR?
Me?
Yeah.
I mean, I think it has a role early on. You know, I have a kid right now who has MPFL reconstruction with a Fulkerson's osteotomy. And so what we're discussing, we live that. Yeah, I mean, I think you can certainly, it's feasible to do with people. The LOP 80% deal with that, and progress from there with it. But man, you're just with issues like that, and what the question that Kyle's talking about, it's just the progress is really slow because you have a lot of limitations, loading wise, deflection wise. So you have all this other stuff. I mean, so you're pretty limited with what you can do with that individual. So, but yeah, I mean, we did it. So.
Yeah, even just long arc quad without a weight at the start is something they can do.
Yeah.
So,
thing.
Yeah, gradually get them moving and bending that knee and doing stuff. I mean, that's you got to grade it. You got to kind of figure out what you can do, and then just add BFR to it so you can load them properly.
All right, do we answer the question?
I think we did a good job answering the question.
Got your Kyle's perfect world. Let's optimize, individualize, right? And then
that's what people ask us for.
Oh yeah.
People don't ask us for what can I do within the constraints of the American healthcare system. I ain't got that question one time.
I have.
You know? I mean, they don't ask you what can you do, because they can tell you that. They know. Now they might ask you, how would you adjust this based on 3 times a week? You know, but they can figure that out. It ain't hard, you know.
The question that I get all the time is BFR worth doing 1 day a week? Because I get a lot of patients that I only see 1 day a week. That's the question that I get more.
And that answer is, well, it is if it depends. Resistance training isn't worth that if you're only doing it 1 day a week, unless you're able to max out, right?
Unless you have somehow figured out how to educate.
That's a physiology question.
Yeah, you can maintain muscle strength 1 day a week
in a healthy person.
Yeah.
Or yeah.
Well, I maintain is a. I mean, if we're going to talk about the American healthcare system, don't use that word. You know, unless you're talking about an older person with a progressive disorder. because
But
CMS
yeah,
will
it just depends on
chop
the
down on you,
context of the individual.
all of it.
Well, my answer is typically that obviously we're probably going to need the patient to do their due diligence of getting some meaningful exercise outside of what we're getting in a 1 day a week application. But if all I'm left with in that 1 day a week in clinic is too low of an intensity that it would be meaningful, then I think BFR with that 1 day is going to be better than no BFR. Now, again, I don't know that that solves all the problems, but I would be pushing for the most intense application I can get that patient to do with that 1 day a week. And
I think that's it's a tricky question, Ben, because you almost have to follow that up with a question and say, hey, what are you asking me? Are you asking me, can this person get the same benefits out of 1 day a week? Is that the question you're asking me? Or are you asking me, is there some sort of stimulus that I'm providing with this one session that can matter so that this person can kind of go on and do something? Because in the end, it's like, well, we know one session a week is not going to increase this stuff. We're not going to see changes in these things that we're wanting to see changes in a rehab type setting typically.
yeah, and I typically preface my answer with we don't have data. I've never seen data on 1 day a week BFR. So I can't really answer with any kind of confidence of what you're going to see. But if it was me and I had somebody who could only do low intensity exercise, I know what I would be choosing to do with that session. So,
Agreed.
yeah.
I've kind of
Cool.
done the 1 day a week thing because I'm always like, I'm going to start doing BFR out of my workout room, and I'll start it and I'm like, this sucks. And then I don't do it again. Then the next week I'll try. I'm like, I need to do that, and I'll do it again. Doesn't seem to work.
It's all good until
Consistency
you
is key.
do. Yeah, it's all good until you do hamstring curls, and then you're like, I don't think I really want to do this anymore.
I even do those without BFR. Those are terrible.
I think the other thing that I would say too, on the once a week deal is you have to find a way to equate if you equate the volume, I think you're going to kind of be somewhat decent. So that's one of the great things with BFR. I mean, I always give the people the example of, if someone comes into the clinic twice a week, we just do 2 exercises for like a lower extremity, leg extension, leg press. I mean, that's technically 16 sets of resistance exercise to the quads, in that week, 8 sets each day. So you're probably going to be pretty good. But, if you can equate that volume, if you just ramp up that single session compared to what someone's going to get in over a week, I mean, I would say you're going to be somewhat close. Maybe not exactly where the higher frequency is going to be, but it should fall somewhat there.
You're doing something.
I'm not sure what you're saying, Zach. Equate volume. What I'm hearing is if you will do a third BFR exercise, then you've done enough volume in that 1 day a week. Is that what you're saying?
Yeah. So basically, let's just say someone's
The
going to
third
do
BFR exercise targeting whatever muscle you want to address.
that's right. That's right.
Yeah.
Versus the person who does 6 sets, the uh 2 exercises, 3 sets in each exercise. They do that twice a week. If you just pack that in to once a week, whether that's because of a scheduling issue or whatever the reason may be, you somewhat should be pretty close. Maybe not necessarily ideal or, from an absolute standpoint. I believe there's just a systematic review that actually looked at this.
Yeah.
So.
Yeah, I've never really known how the volume per week would relate to a single day exposure to that volume.
So what you're doing is you're packing your week's worth of training
Into 1 day.
into 1 day. And
Right.
when you
Yeah.
equate that, you get your number of sets, your weekly volume, it should be somewhat close.
Do you use a wheelchair or walker the next day after
Yeah,
you do all
well,
that volume?
if we
Or
want to see rhabdo happening in the clinic, that's we're on that
I'm thinking
path
through this
here.
to myself, and I'm like, yeah, okay. No, but yeah, I mean, I saw that paper as well, Zach, and I mean, a lot of what we see is if overall volume of work is the same,
Yeah,
number of
that's the
sessions you
key.
use to get there doesn't matter as much. But
Yeah.
yeah, that's tough to get all your volume into one session.
Yeah,
It's like these new protein guidelines. Well, if you can get all your protein in one meal, it seems like it does pretty good. I mean, based on that new study, that's pretty interesting, you know? So just, if you miss it all throughout the day, load it up. All right,
Man.
man. Any parting shots? Appreciate the question, Drew. You guys keep them coming. If you guys are looking for more fun banter from us, we have lots of podcasts out there. Please like and subscribe. It helps us out. Go to Owen Recovery Science. We have all sorts of courses on there, conferences that we'll be speaking at, and BFR content out the wazoo. So you guys please visit us. We appreciate you all listening to us and listening to Kyle with the bee in his bonnet for a little bit there. That was fun.
Happens.
Got to twitch it. All right. We'll see you guys next time. Peace and out.